For this chat, I'm gonna explore some concepts of moral psychology and try to show how they apply to psychiatry. And it starts a little bit loose, but you will see how it gets a consistency. So, moral psychology tells us that there's two ways to go about morals. One pretty much is it goes like this: we are all good people. Right? We're all good people. Nobody, most of us at least, don't wake up in the morning thinking, oh, what kind of evil deeds I can do today. No, we have morally, we have the perception that we are good, each one of us, with exceptions. We know there are exceptions, of course, and I'm not going to dwell on that. So, if I am good, the things that I do are probably the right things to do. For example, someone stays in a miserable marriage for, say, 30, 40 years. For that person, staying on your marriage as bad as it is the right thing to do. Now, someone who divorces will say otherwise, will say no. The right thing to do is to pursue happiness. And then the person that stayed in the marriage may say, well, but it's the best thing for your kids, and may claim that there's some data to support it. But the divorced person is going to say, well, I don't want my kid to stay in a miserable marriage later when it's his turn. So I'm giving him a role model on how to live life, and so on, so forth, so on. So in other words, we define what's moral based on the things that we do. It's very convenient if you think about it. But it comes from the premise that none of us are, too particularly evil, and we are all doing the best we can, let's say, acceptably, right? Nobody's doing terrible deeds out there. Oh, no, I shouldn't say nobody, but most of us are just fine. Especially in our field, we go to the field of psychiatry or mental health in general because we are sensitive, because we are empathetic, because we want to help people. Does that sound familiar to you? And why do I ask that? Because that's exactly how we read psychiatry. We don't have, just like in morals, we don't have clear-cut rights and wrongs. So if you remember in my last episode, I mentioned, I think it was the last one, I mentioned that if you ask 10 psychiatrists which one of them, individually, which one of them is the best one in that group, you're going to have 10 different responses, 10 different answers. And the reason for that is because the criteria kind of follows the same path as moral does. So someone who doesn't prescribe antidepressants for people with bipolar disorder will say that's the right thing to do, and is going to quote some studies. And the guy that says, well, I do prescribe as long as they're taking mood stabilizers, is going to quote some studies, and they're going to think that's the right thing to do. In morals, there's a different way to ascertain what is the moral thing to do. And that involves deciding what is harm. So first, you define harm, and you define a hierarchy of harm. And the less harmful thing would then be the moral thing to do. It's a very difficult task in the field of morals, and it is a very difficult task in the field of psychiatry. But it's a way better approach than just assuming that everything we do is right just because we're good people. How do we decide? And this thing about deciding what harm is really just an effort to have a parameter. So we can say what is a better and what is a worse psychiatry, right? So do we have rules to decide what harm is? Because remember, medicine starts with first do no harm, right? First do no harm. So applying to psychiatry would go with questions like, okay, so for example, there's a patient with overwhelming anxiety, right? what is the harm in this case for a psychiatrist? Is to let the patient experience the anxiety or to prescribe a medication? Which one's more harmful? Offering a medication instead of offering exploration on the reasons for the anxiety. Which one is more harmful and which one is less harmful? Hence should be tried first, or not only first, persistently. When we decide for a medication, we're going to say, okay, what is more harmful, PRN use or chronic use? Remember, we spoke about it before. Once you go into this kind of discussion, risk-benefit analysis, you have to have a good picture. It's impossible to have this discussion if you don't have a good picture of how well your medications work. And we have already covered the issues with antidepressants, the number of negative randomized control trials of many medications that were FDA approved that we use every day, right? So, or maybe false advertising lawsuits against pharmaceutical companies over medications because they hid side effects or they advertised it for things that were not FDA approved or that the data was not sufficient to show or to recommend use. So that's a very complex discussion, right? But let's go back to a more simple level. So what is harm? Is chronic use or PRN? And then you go, so well, PRN should bring less harm when it comes to a psychiatric medication for the most part, but assuming it works, would the medication prevent the patient of learning to address his problems and learning how to maybe tolerate anxiety or cope with it, or maybe address the cause of the anxiety? You know, like just like drinking would take your mind away from problems, but not necessarily help you address the problems. So prescribing medications versus not prescribing medications in the long haul, what is more harm, right? And then you say, well, what kind of medication? Well, let's start with the antipsychotics for anxiety, right? The major tranquilizers. What is more harm, to let the patient suffer with anxiety or to give him an antipsychotic? Right now, immediate relief versus long-term side effects. We know very well the long-term side effects of antipsychotics. Or it's SSRIs, right? What is more harm? Let the patient suffer from anxiety or from sexual side effects of SSRIs that many times are irreversible, according to some publications. How about suicidal patients, right? What is more harm, to let a depressed patient having suicidal thoughts or to prescribing an antidepressant? Well, how well antidepressants work for suicidality? So what is more harm? How about an antipsychotic? We already know that antipsychotics kill more than suicide among patients that meet criteria for major depressive disorder, right? So, and when I say, well, short-term benefits, long-term side effects, right? Let's say someone could claim, oh, the patient's 40s, is in his 40s, he's at his apex, right? He needs to be productive, he needs to get through his life. When he gets to his 60s, if he has TDs, if he's dementing, if he's falling, if he has obesity, diabetes, that's another conversation, man. How about now? How about relief? What is more harm, right? We don't have answers for those questions. But there's kind of a solution for it, but we haven't, as a field, sat and looked into this thing, as basic as it is, to say, when are we hurting more than helping? When is better to just let go, just let be? You know, we haven't covered those things. Our field was not designed with those questions, because our field actually flourished after interventions, medications came about, and you know, that was the point, just to give medications. So every rationale that could justify giving more medications was adopted, which goes back to the first type of moral. If I'm doing this, should be the right thing to do. If this is what is available for me to do and I'm doing, must be the right thing. And that's how I judge the world, right? For the suicidality part of it, as I was saying a second ago, and I hope I'm not being too confusing. We have lithium, right? So lithium seems to have some efficacy for suicidality, even though you can question if it's effective. But it brings a lot of side effects. So what is more harmful in the situation? No treatment, address the causes, psychotherapy, or lithium, or all together? Will lithium have deleterious effects? And then if we can actually answer those questions, then we have a sense of what is to be done. Just like in morals, we decide what harm is first, right? So a very easy answer, very easy, would be, which is better than what we do now, even though not fully appropriate, but an easy answer will be, the decision is not ours. The decision is not ours. And that may be the answer in many cases. So, meaning, the decision of what is most harmful to be avoided in the case of a patient does not belong to us. It belongs to the patient. We present the options, we hear what the patient is going through, we hear it, we try to understand, right? We can use any framework borrowed from psychology. At times we find clear reasons for the suffering. At times the reasons are kind of at a deeper level of understanding. But then you say, okay, these are the options that you have. And then you present the side effects. You point out the low efficacy of the treatments, because all our treatments have very low efficacy. And you also present the difficulties of coming off our medications, right? Just taking antidepressants into account, we have 50% of patients having moderate to severe withdrawal symptoms from antidepressants, to the point that, other countries in the world are changing their policies when it comes to withdrawal and tapers of antidepressants, while United States, as usual, is falling behind because we follow a very heavy financial agenda. And then you take all that information and you put that in the hands of the patient. Now, I have to say, it is a much better alternative than what we do nowadays. And what we do nowadays is, because that's how we were trained to do, not because we're evil doers. We're not evil doers. We're just trained to think the problem like that. The guy comes, says, I have low mood, I can't sleep, my appetite, energy, and blah, blah, blah. And then you say, all right, I'm going to give you sertraline, say. And then the guy says, what are the side effects? So the side effects are, you can have a little bit of a GI, a little bit of a headache. You're going to start very low dose. And, you got to reassure the guy, and he ends up accepting. That's what most of the time is done. How do I know? Because I have done that in the past, and I have seen people doing. I don't do that anymore. What I do nowadays is I present a list of side effects based on percentages from different sources, and I put the decision in the hands of the patient. Do you want to take this? This is an option. This is what most shrinks would offer you. I just need you to know as much as I know about their side effects so you can make your decision. In other words, I'm saying either, not with those words, but I'm saying I wouldn't take this medication because this, and that, or I would take this medication because this, and that, if he asks my opinion. If he doesn't ask my opinion, I'm just saying this is the option. These are the side effects. These are the effectiveness. And is that great? Coming off of it may be difficult for a fair amount of people. Okay? You can have sexual side effects. You bring up the things that matter, right? And you put the decision in the hands of the patient. Because really, deciding what is harm in that sense, at that level, is not up to us, because we haven't set together APA, and it doesn't matter. Nobody sat together and say, hey, it looks like antipsychotics are worse than low mood with suicidal thoughts. What the hell, right? How come? For what? Oh, for suicide, for death. Oh, okay, how about other things? We haven't had that conversation. So we don't have the right to make the decision. So we present to the patient. Then someone will, obviously, as I would, object and say, how about benzos, stimulants, and opioids? Yes, but please pay attention to the detail. The decision of what is being offered to the patient, based on what we know, which is not a lot, it's yours as a professional. If the patient is going to take or not, it's his. If he's in a danger to himself, so sorry, we're bound by law. Call 911. We are bound by law. All right? It's not. People think that we have an unspeakable pleasure if you see criticism. There's good criticism. I always point that out. Anti-psychiatry movement has a lot of very good points. But some of the points they have is that we commit people against their will. Dude, don't fight with me about that. Go over the governor, the representatives, and change the law. Okay, the law is relatively clear, and we're bound to it when it comes to mental health. So no, that's not our fight. Well, we can help them fight it, even if they want to have discussions over the right to commit suicide, which I'm not going there. No, we are not. I'm not saying the patient comes to you and says, "This is what I want to take," because we know that someone who has an addiction will say, well, yeah, no, that's what I need right now, brother. I need lorazepam. I need Percocets. This is what I need right now. I need Adderall, right? I need stimulants, amphetamines. No, that's not how it goes. We listen to the story, we see if it makes sense based on the little we know about this freaking field, and then we present the choices. Taking or not taking is not your choice. Fair? What is more or less harm is a decision of the patient. And we're going to call that, and I didn't invent that, I wish, shared decision making. Okay? It's a bit of a compromise, a bit of a negotiation, and so forth, so on. Because we don't know what's harm. We haven't yet decided in our field what is harm. We also don't agree very well with what success is. Because at the same time we have the absurdity of PHQ-9, right, which is a measure of symptoms. That people come to your office, fill the list of symptoms based on a fairly arbitrary criteria for major depressive disorder. And you give a medication, and then they come back and they look at those symptoms, and then they fill it again. In no moment the medication or the scale is addressing the reasons for depression. Why? Because it's convenient to assume that those symptoms are stemming from a brain disease. It's convenient to assume that a brain disease is involved in it because it's what maintains the market. Right? What is Zoloft? What is sertraline against a divorce? What is sertraline against unemployment? Will it change your reality? But we covered that in other discussions. I don't want to repeat myself. For schizophrenia, for example, what is success? Stay 12 months out of the hospital, have a suppression of auditory hallucinations, or later in life work and have a meaningful life and a family and a job, or go to school and, experience life, as opposed to be numb or with cognitive impairment stemming from antipsychotics. So what is the harm here? Allow someone to go in and out of the hospital many times, and God knows the dangerousness that may be associated with it. Or the harm is to prevent their lives later, to hold them back later because of chronic use of a medication that will cause tardive dyskinesia in a very high rate. And it's a very limiting, it's an awfully limiting presentation. The patient needs to know those things. That is what we should be doing when we use the expression informed consent. As opposed to say, do you want to take it? Yes, okay, consented. No. An informed consent is give the information, the one you would use for yourself. How about that criteria? To take or to decline a treatment. So, in other words, Dr. Timimi, Sami Timimi, I interviewed him back in the day last year when the podcast was named The Psych Experience. It's only on Spotify. But he said, psychiatry is the philosophical branch of medicine. And I think that's a very appropriate description. It's psychiatry is the medical art of the debate, where the medical art of collaboration with the patient. To practice psychiatry like the way I'm proposing requires a huge ability to tolerate uncertainty and anxiety and to be open-minded. And then, of course, a fair amount of writing skills to explain the thought process and to put on paper the patient's preferences without, because obviously every time you use your brain to practice psychiatry, you're going to be doing something different of what people would think standard of care is. But the matter of fact is that standard of care contemplates the use of informed consent. Do we do informed consent? We don't. For the most part, we minimize side effects and, hate to say, we push pills as a field. Not all of us, not you. I know you wouldn't be listening to me if you were like that. So once you adopt this mindset, as opposed to like most of us would do, that is, to listen different ideas and say, well, I wouldn't do that, so that's certainly wrong, which is the moral approach to psychiatry, the more traditional moral approach. And we switch to a let's define harm approach, or let's work on shared decision making here, and I'm going to present all the information to this family and to this patient so they can make their own call based on the best available information and unbiased above all, because a lot of the data we consume is financed by the guys that sell the drugs, which is kind of stupid, but here we are, right? But once you start doing that, once you start showing to your patients that your investment in them is much bigger than your investment in the procedure, means I hear what you have to say, I offer a drug. That's the procedure, right? And I write it on paper. When they perceive that you are not as invested in the procedure, where they perceive that you have your questions about the efficacy of meds, what's going to happen to you is has happened to me over the past year and a half or 2 years is maybe 7, maybe 8 out of 10 patients would say, let's review this next month. All of a sudden, as it happens to us when I ask the question, if you were feeling down, would you take Seroquel, right? Or would you take an SSRI? Most colleagues, when I ask that question, as a virtue of my position and of my mentoring institute, say I wouldn't. I would first work for solving the problem. We all know that's what's bringing you down. Or do psychotherapy or exercise or diet to change my life somehow. Once your patients perceive that's where you are, that's the kind of approach you have, what's going to happen is most of them will start looking favorably towards movement, towards action, towards addressing the problems they have in life that are causing, the low mood, the anxiety, the distress, or finally address that history of trauma that needs to be addressed, or accept, you name it, because every time we talk about psychosis, the discussion is a little bit different, even though everything applies to it as well. But it's a more dangerous waters to navigate. It makes people get more emotionally reactive, and I'm trying to avoid that as much as I can. So once you do that, once your patients read you, and that happens with patients that you're inheriting as well. When you say things like, well, most patients don't take medications every day. Most patients don't perceive their medications as helpful, right? Antidepressants don't bring remission to much more than 20% of 30% of cases. The patients will start telling you things like, well, I'm going to confess something to you. I don't take the medication anymore, or I don't take it every day. And you start even finding people that are doing great with a history of psychosis that meets criteria for schizophrenia. saying that I don't take them every day. I take them every 2 days. I take them when I hear the voices. I take them every other day. At times I don't take for many weeks, and then I start hearing voices. I take again in a matter of 1 or 2 weeks. I'm better, and they're doing great, and they're confessing that to you. And now you say, well, the patient has been doing this successfully. Why would I push more? He's not having too many side effects. The symptoms are under control. He's satisfied with the result. He's not a danger to himself. Do I have grounds to push drugs upon this guy? And the answer, you don't. So you follow his lead. Once you adopt that, you're going to realize that a lot of your patients have a very reserved opinion about medications. Not that they think they're not useful, because they are useful. Our drugs have their utility. But they're going to be more forthcoming to you and say, hey, now that you're mentioning, I think I want to wait another month. Or, well, I have been taking here and there. Or I don't take every day, and all those things. Some of my coworkers, because of this position, think I don't prescribe medications. And I do. I do prescribe. Every medication that you prescribe out there, I assure you, I also prescribed. The difference is that I'm not invested in prescribing it. Okay? When I present the facts, my patients make different decisions that they used to make before, when I used to work in a more kind of a traditional run-of-the-mill way. And of course, there's the cases where I would say, listen, if I was on your, not with those words, but my position would be that if I was on your shoes, I would take it. I would take it. I think this medication can actually bring a lot of relief for you. And if I was you, I would take it. I still have to present information as it is, because the decision is not mine. If the patient's a danger to himself, we are bound by law. The discussion ends there. It just so happens that maybe everything that we were taught in our psychiatric training is actually valid. It's actually valid, but is unlikely to be valid, according to our data, for the majority of our patients. If anything, the opposite. It seems that everything we do is the things that we do on a daily basis, you're sad and depressed and anxious about this and that, but seems to be a state of exception. However, because you cannot make a market of the state of exception, it was generalized for every single presentation, even though we are mental health providers, even though we are the guys that should take into account the individual. We are the guys that claim that individual differences matter. Well, those were translated into, well, if he has insomnia, then should be a sedating antidepressant. Well, if he has high cholesterol, then should be aripiprazole. Well, so that's how the individuality translated, as long as the drug is at the end of the line. So in other words, and to summarize, we don't have a criteria to say we haven't decided what is harm in our field. As such, the decision of what's more harmful should not be ours. Within a window of treatment options that make sense. Again, recalling that we mentioned benzos, stimulants, and opioids. It doesn't matter how much someone may say this is the best thing for me. You're going to say, well, buddy, yeah, that's not quite what it seems to be the case. There's other factors there. But within the things we can offer safely, the harm decision belongs to the patient. What's more harmful, what's less harmful, unless we have dangerousness well documented or evident. And the absolute lack of that discussion of what is harm and what is success in our field is what allows this phenomena that if you ask 10 psychiatrists which one is the best, they will all have most likely different answers. If you do that with quarterbacks, they'll have to agree that there's a better quarterback out there. If they do that with goalkeeper in soccer, they have to agree. They say, well, this guy seems to be the best in the world. If you do that with race pilots, if you do that with artists, for the most part, you can say, well, yeah, I guess this guy is the best one right now. You have more criteria. Even with art, we have more criteria to say what's good and what's bad than we have in. Someone would question postmodern art doesn't, but I'll refrain from that discussion. But they seem to have more criteria than what we have in psychiatry. And here's the proof. I work under these standards. Those are the ones that matter for me. So I'm the best psychiatrist in the world. Thank you for listening.